Assalamu alaikum. Today we are going to read AKP clinical case number 14, that is a 6-year-old boy presenting with pallor. A 6-year-old boy who admitted in hospital with pallor, tiredness and ongoing bloody diarrhea. He had a history of being unwell a week earlier with a 3-day episodes of abdominal pain, vomiting and diarrhea, which then progressed to bloody diarrhea. Since then, his appetite and fluid intake have reduced. He has been sleeping more and his urinary output decreased, suggesting possible kidney issues. On examination, he has fever 38.3 degrees centigrade and a fast heart rate 140 beats per minute. He looks pale and quiet but has no rash or other skin changes. His abdomen is mildly tender with a palpable liver 2 cm. The blood test reveals the following abnormalities: low hemoglobin indicating anemia, likely caused by hemolysis; low platelet indicating thrombocytopenia; high urea and creatinine suggesting acute kidney injury; mildly elevated liver enzymes and bilirubin, likely due to hemolysis; and mild liver involvement. These findings, low hemoglobin, raised bilirubin, as well as thrombocytopenia, strongly points to hemolytic uremic syndrome, a condition that primarily affects the kidneys and is often triggered by an infection with Shiga toxin producing E. coli. Hemolytic uremic syndrome is a condition caused by damage to the blood vessels, particularly in the kidneys, leading to the hemolytic anemia, thrombocytopenia, and acute kidney injury. Over 95% of hemolytic uremic syndrome cases in children follow a diarrheal illness, especially bloody diarrhea, caused by Shiga toxin producing E. coli infections. These bacteria produce toxins that damage the lining of blood vessels, leading to the characteristic symptoms of hemolytic uremic syndrome. Symptoms which we already know that are in this case are bloody diarrhea, pallor, tiredness, reduced appetite, decreased urine output, and lab results shows anemia, thrombocytopenia, high urea and creatinine, bilirubin elevation, likely cause Shiga toxin producing E. coli, specifically the O157 strain is the most common cause. Infection is often linked to eating contaminated food like undercooked meat, drinking unpasteurized milk, or exposure to farm animals. So this is strongly associated with hemolytic uremic syndrome. The history of bloody diarrhea followed by anemia and kidney injury is typical Shiga toxin producing E. coli associated with hemolytic uremic syndrome. So this is the answer of first question, is E. coli is the likely causative agent for this clinical presentation. Let's rule out the other option, Campylobacter coli. Campylobacter infections can cause bloody diarrhea, but they are more commonly associated with Guillain-Barré syndrome rather than hemolytic uremic syndrome. Hemolytic uremic syndrome is rarely linked to Campylobacter infection, and absence of prodromal symptoms like crampy abdominal pain that are characteristic of Campylobacter. Second option, Clostridium difficile. It is common in antibiotic-associated diarrhea, which is not a feature of this case. No history of recent antibiotic use, and it typically causes pseudomembranous colitis rather than hemolytic uremic syndrome. And bloody diarrhea is less common unless severe colitis occur. Next option is Salmonella enterica. Salmonella can cause bloody diarrhea, but is more often associated with reactive arthritis or typhoidal complications. While rare strain of Salmonella can trigger hemolytic uremic syndrome, they are much less frequent compared to Shiga toxin producing E. coli. Next option is Yersinia enterocolitica. It typically associated with mesenteric lymphadenitis, mimicking appendicitis, and rarely caused hemolytic uremic syndrome. More common in colder climates with characteristic symptoms like pharyngitis and joint pain, which are absent here. Second question is, which of the following is a recognized complications? Select one answer only. So, microvascular damage caused by Shiga toxin can affect the pancreas, resulting in pancreatitis. So, this is a recognized systemic complication of hemolytic uremic syndrome. Let's rule out other options. Pelvic abscess formation is not typically a feature of HUS. It more commonly associated with gynecological infection or in perforated bowels, not microangiopathy. Septic arthritis is not associated with HUS. Why? Because here joint involvement could be seen in reactive arthritis following Salmonella or Campylobacter infections, but this is not relevant here. Next option is subphrenic abscess, unlikely in HUS as it usually arises from post-operative complications or perforated viscera. There is no evidence of such pathology in this case. Next is ulcerative colitis. While bloody diarrhea is seen in ulcerative colitis, the patient's acute onset of symptoms, history of preceding diarrheal illness, and presence of HUS triad are inconsistent with chronic inflammatory bowel disease. This case emphasizes the importance of recognizing the symptoms of hemolytic uremic syndrome early, as timely supportive care can significantly improve outcomes. Thank you for watching. If you have any question regarding this case, comment below, like, subscribe, and share.